So next up, we have Stan Kachnowski, who is Dr. Kachnowski is the chair of our HITLAB and director of digital health strategy program at Columbia Business School. And he interviews Dr. Kalmet about a study that he's doing with comeback mobility. And this is around real-time load-bearing data analytics and reducing cycle times for orthopedic rehab. We're looking forward to hearing this one.
So next up, we are extremely fortunate to have a guest who has been using the comeback mobility technology and can talk a little bit about his experiences with it and its benefit for patients who are undergoing rehabilitation for lower limb injuries. Again, comeback mobility is a smart crutch tip that is implemented. Again, we've tested this out at the lab. It can be deployed in about 5 minutes. It's a smart crutch tip that goes at the bottom of a crutch and ties to an app via Bluetooth. Very simple implementation, and generates tremendous data on weight-bearing activities. And again, very happy to have you on the program today, Dr. Kalmet. Thank you for joining us. First, if you could tell the audience a little bit about your background.
Yes, I am Dr. Kalmet. I am doing at the moment orthopedic surgery, and I have done a lot of research about weight bearing, creating protocol permissive weight bearing. In the past, I have done research with devices who will monitor the weight bearing. For example, the multi-cone insoles, the Sensi Step boots, and now I will do some research with comeback mobility crutches.
And that's exciting. Tell us from your experience from using crutches and using various types of aids for lower limb rehabilitation. How do you think comeback mobility will improve patient outcomes?
First of all the patients with fractures of the lower extremity will use crutches, and the patients needs to walk as soon as possible. But the trauma, the fracture, and the symptoms they will get with the trauma and the fracture will restrict them to bear weight, and they need a lot of feedback, and they need support from the physical therapist, and they need prescribes from the surgeon who will allow them to walk as soon as possible without restrictions. So I think the devices on the market are limited, and there are only a few devices who are validated for clinical research or for patients. The comeback mobility as the device ambulant who will give you feedback to the patient, and I think the device will go with the patients for a long time. The devices I have worked with before, they were also good tools to work with or to get feedback from, or who will monitor the weight bearing. But these devices will go only for a small period, and after that they broke. They will not work very good for the patient, and these are too expensive.
Yeah, that's a fantastic point. And I think that's one of the things we found at HITLAB when we were using the comeback mobility device, was that not only did it provide tremendous data, but it was commercialized for long-term use, and the actual device itself had an incredible battery on it, so that you could use them for 3 to 5 days before they need to be charged again. So just an incredible way to be able to collect patient data and not have to worry about the ruggedness of the device and its ability to actually carry forward over a longer period of time. And so that's something that when we're testing devices at the lab, we're constantly looking at breakdowns. Some studies that we've done, we've had breakdown situations where almost 15 to 20% of the devices would break down over the course of a 3 or 6 month study. And that presents tremendous pressures on the study team in terms of having to find replacement devices and having to constantly do that. And so that's another win for the comeback mobility team. That's absolutely an important point to remember. And then, like you just said, the battery, certainly having the battery power for the device to be able to work for days at a time without having to be recharged every 24 hours. That's another area of weakness that we found on many devices at the lab that we've tested, and certainly something that is a great point to bring up here as well. Thank you for bringing that up, Dr. Kalmet. And in terms of the study that you're doing with comeback mobility, can you tell us a little bit more about what the hypothesis is that you're testing in the study? What is the study hypothesis that you're testing with comeback mobility?
We will start a study using the comeback mobility crutches and calcaneal fractures. And we know from our experience that the calcaneal fractures, they are bad fractures. The patient after the operation is not allowed to bear weight for 12 weeks. But within our new permissive weight bearing protocol, we will let them bear weight immediately with help and support of a physical therapist and with feedback from the comeback mobility crutches. And we think is that if they will have the aftercare with the permissive weight bearing protocol and with the feedback they will get from the crutches, they will get sooner walking and back to work 8 weeks sooner. So that will be 8 weeks faster of rehabilitation. That's a great difference between the new permissive weight bearing protocol and using the device for feedback and the current guidelines.
And that's invaluable. Okay, so that's a very important study hypothesis. And when we start looking at things like reduced cycle times for rehab, that is something that every patient wants to see. Obviously, every physician wants to see. I think that's something that will be fascinating as we're seeing your study results come out over the next 6 months. That's exactly what we do at HITLAB. Is we like to see studies that are showing real evidence of how digital technologies are improving patient care, patient outcomes. So really appreciate that. And just as we wrap up, if you can please tell our audience a little bit about what other things you're working on these days at your institutes and what other studies you're working on as well.
I'm working on permissive weight bearing and intra-articular fractures of the lower extremity. So that means from fractures from the pelvic till the foot, and these are a lot of fractures. And we are now implementing the permissive weight bearing protocol in our region, and we will implement it in the Netherlands and further in the future internationally. So that means that will take a lot of time and work. And after we will get more evidence in permissive weight bearing and all of type of fractures. So specific for calcaneal fractures, specific for knee fractures, or leg fractures. So yeah, that will also take a lot of time. And in addition, we did already a cost effectiveness study where we investigated the permissive weight bearing versus the current guidelines, non-weight bearing. We saw good results with that means with better activities of daily living for the patients. And next to that, 450 euros cheaper per patient for 6 months. So these are good results. We want to go further with the research about that.
Dr. Kalmet, I have another question for you about how physicians actually prescribe and then manage weight-bearing activities with their patients that are going through lower limb rehabilitation. If you could please tell us what is the standard of care right now for physicians prescribing and then managing weight-bearing activities with their patients?
60 years ago, the surgeons were operating, and there happened a lot of things when you operate. So there are a lot of methods how to operate, a lot of methods how to use the fixation, or how to or what kind of material you have to use. But they didn't investigate, and there is no evidence about the weight-bearing guidelines. Weight-bearing guidelines are not evidence-based, and they are now for 60 years non-weight-bearing. So that means if you have a fracture of the lower extremity, the current guideline is now non-weight-bearing. And it's all about the surgeons were good in operating, and they said, okay, we are good in operating. We want a non-weight-bearing aftercare for our patients. The experience went further to the surgeons now at the moment, and we have to ask the surgeons in the Netherlands, what kind of weight-bearing protocol do you use for patients with tibial plateau fractures? So that means knee fractures. 90% of them deviate from the current guidelines, the non-weight-bearing guidelines, and the local own guidelines. So ask yourself why you have a guideline. The next question was, okay, you are deviating from your guideline. What's the reason to deviate from your guideline? And the most of them, 40% of the surgeons answered the question why they deviate. It's because of clinical experience. A lot of them also said, they have a gut feeling about the weight-bearing aftercare for the type of fracture, the type of fixation, and the type of patient. So there is no a straight weight-bearing protocol can be used for by the surgeons for the patients. So that's why we have written a permissive weight-bearing protocol.
That's fantastic. And just again, I think that shows the importance of this study relative to the other studies that have been done to date. Outstanding.
Yes.
Wonderful. Wonderful. Again, really appreciate you joining our program today. Congratulations on all of your terrific research, and we look forward to having you join us again in 6 months to hear about the results of your comeback mobility study. Thank you very much, Dr. Kalmet, for joining us today. Take care.
Thank you. Thank you.
Awesome. So thank you, Stan and Dr. Kalmet, for that great discussion. A perfect example of where data really becomes information and is ties in so nicely to this discussion.